Hey, it's me. This video is just educational, and I'm just giving you a little glimpse at today. We're going to talk a little bit about the major tray. The major tray is a common tray used in a lot of procedures. They stem off a little bit to other specialties. You can have vascular, orthopedics, and sometimes a general tray could be added to that. We're going to go over some simple instruments. If you're in school, by the way, I'm Brad. I'm a first assist. I'm also the clinical coordinator here at Southern Technical College, which we are located in Port Charlotte, Florida. I put videos on for the students, and obviously it's for educational to see. Strongly ask you to ask some comments in the video, and obviously subscribe if you can. That would be nice, and hit that like button because it's all about the algorithm. So today we're going to talk a little bit about the major tray and some of the tools, some of the do's and don'ts, and some of the uses for these tools. Let's get right to that, okay? Yeah. This is your general tray, otherwise known as, in some hospitals, they'll call it major tray, or sometimes they'll call it a general tray. This tray can come in many varieties of instruments, but for educational purposes, we're going to go over a couple of the most common type of instruments in a general tray. Now, what is general, right? Gallbladder, spleen, colon resection, anything within that abdominal cavity, right? Typically used in general tray. Probably the most common tray you're going to use, in my opinion, in surgery. I'm going to go over some of these instruments one by one. Are you ready? Let's do it. Zoom out just a little bit. We're going to start off a little bit to your left. We're going to start off with the towel clamps. Wow, here we go. Basic stuff. When you do your counts, maybe a pro tip, leave your stringer on. That's something I typically do because obviously when you count, things get out of order. But let's start with the Backhaus towel clamp, otherwise known as the non-penetrating towel clamp. I typically use it for clamping things on the field, right? CST exams will typically ask you when you clamp on your drape, what type of towel clamp would you use? Obviously, we don't want to use the next one up is a traumatic or a penetrating towel clamp because you can actually go through the field and actually cause strike through and contamination. Next up, typically is the next towel clamp, penetrating towel clamp. I call it the Edna, but it's a penetrating type of towel clamp. Traumatic, right? It has very sharp edges on it. Can get used, and I've seen it used in surgery, laparoscopic surgery. You know, trying to lift the skin up as you're putting trocars in, especially if you're a Hassan type of trocar or you're doing a cut down. You know, it does get put onto the skin for many different fashions. You're also going to use this as squaring the towels. As you're squaring off, you can actually hold the towels in place that way. Very sharp, very careful. Do not, I emphasize a lot, do not use this towel clamp to hold down instruments such as your Bovie holster or anything in general, because look, you can easily go through your drapes, right? And it goes right through. Next up, typically, now this is where I have a lot of debate on here. You're progressively getting a little bit larger in your clamps. A lot of these fall under the category of clamping and including. Mosquitoes, you know, also called stats, but typically the smallest of the clamping and including. What is the use for it? You know, I guess vascular, you can use suture boots on here when you're putting it on double-armed kind of sutures like Proline. Protects the thread that way. Mosquitoes are the smallest of the clamps, typically called mosquitoes or small hemostats, but as they progressively get a little bit bigger, you'll see how small, and obviously they get bigger because guess what? Not everyone's anatomy is the same, especially if they're blunt dissection. Maybe they need to get down a little bit further. Some tissues are a little bit tougher, but the mosquito is a typical clamping and including. As you get a little bit bigger, they call it Kelly's. I call it hemostats, right? I think there's an argument there based on where you're trained at. Another clamp and including probably the most common type of clamp that you would use in any kind of general tray. Now, I don't know if you can see it. It's medium size. It's called a Kelly's clamp, hemostat, a stat. I mean, a lot of doctors have names for it. But as you can see, it progressively gets a little bit bigger in size. Mosquitoes, just like it's named, very small, right? As it progressively gets bigger, obviously we have a Kelly or a hemostat type of clamp. What are we using this for, right? Your blunt dissection. I think a lot of these, maybe as we get down towards the tonsil clamp, but this also can be used for blunt dissection. You can put peanuts on it, Kittners, a lot of adjusting around the vessel. What else can we do with this, right? Appendix, right? We need to isolate vessels. Sometimes we clamp and tie off with certain kind of ties or ligatures. The appendix, obviously, we're taking the appendix off, clamping it down. This is an open appendix. So it has a lot of multi-uses, but probably the most common type of clamp you would use in a general tray. Next up, as we progressively get a little bit larger in clamps, it's called a Kelly's clamp. I know a lot of arguments of what they call it, but down here in Florida, we call it a Kelly. What do we use this for? Just like any long instrument, in my opinion, you have short and you have long based on how deep you are in what cavity. Just like forceps, needle drivers, they have small versions and they have a little bit larger ones because as you get deeper down into that cavity, what have you, you might need something a little bit longer. Again, these all have the same kind of principle where they're clamping and occluding. We're just progressively getting a little bit bigger. So down here we call it the Kelly. What do you guys call it? I'm just curious where you're from. I'd like to see the different names. Obviously I know what it is, but what do you think this is also called in other places of the country? Next up, we got the tonsil clamp, otherwise known as the Schnidt clamp. Yeah, that's not a bad word. I know we can think of many different jokes about it. Again, you can put a Kittner on here. And what is a Kittner or a peanut? I won't want you to confuse that between, because I know a lot of students confuse Kittners and peanuts with cottonoids, right? Cottonoids are typically for neuro, right? There are different sizes for that. But peanuts they come in little packs. I think, if I recall, there are about 8, and you can put them on the edge of that. Peanuts or cottonoids, what are they for? Blunt dissection, going through the tissues, manipulating tissue out of the way. But you also can use a tie and a passer. Now ties, what are they used for typically? Ligation, vessels, trying to stop bleeding, all that kind of hemostasis kind of thing. We have, chemical hemostasis, mechanical type of hemostasis. In this case, we're going to tie off vessels or tie off structures. There's 2 ways to pass ties to doctors. It's on a passer, or it's manually. It's just given to them by your hand. If you anticipate a lot of ties, typically preload these up ahead of time. So I've done a Whipple before, and you're constantly giving these ties on passers, going around vessels, tying off vessels, you name it. Typically used in general tray. They're called tonsil clamps or Schnitts. That's the more technical name. You can't mistake this one here, right? Probably the most unusual type of name, Babcock. No laughs. But this is what? It's a non-traumatic type of clamp. You tell me what it's used for. I'll give you one example. The appendix, maybe, right? Yeah. How about the fallopian tube? Grasping around that. You can see how it kind of goes around. Non-traumatic can kind of have that circular edge, grasp around, but typically it's a non-traumatic type of clamp, so you can hold on to it, not tear tissue, manipulate tissue. CST exam is going to ask you what is typically you would use for a hold on to fallopian tubes or the appendix, small bowel. It's typically the Babcock's your tool of choice. They probably come in a little bit smaller sizes and a little bit larger sizes, again, based on the anatomy and what they're looking at. and how far you have to go into the cavity itself. Babcocks. Next up, I think we have a couple of selections of Allises. Now, Allises have obviously some teeth on the end here, but they're not as traumatic as you would think. They're a traumatic type of clamp. And this is a little bit larger version of it. Obviously, they can come smaller. And they're used for, what are they used for? General tray. Obviously, they can have a version in GYN tray for A&P repairs or slings or hysterectomies to hold on to the uterus. But in this case, for general, maybe you're anastomosis something. You're doing a small bowel reconnection and end to end. Sometimes you need a couple of these to hold on to and use that linear type of stapler or that GI stapler to reconnect the bowel, right? The Allis clamp. And as you can see, the Allis clamp comes in a smaller version of it. Again, has the same theme there. As you get down deeper in some cavities, you might have to switch over to a larger Allis. Start off with a small one if your colon has been pulled out and you're trying to anastomose it or reconnect it in some fashion. Next up is probably the most traumatic type of clamp that I would imagine, otherwise known as the Kocher. I don't know if you can see it on there, but it has some teeth, right? Use this in orthopedics. I've seen people holding on to the meniscus or tearing that off. We need something to hold on really good. Tear it out. It's to hold on to something and you're not letting go. That's what it's designed for. So if you're doing open, for general sakes, if you're doing open cases, you're grabbing on some tough tissue, right? Subcutaneous, some of that fascia. Now, there's something called a component separation. You know, if you guys want to Google what a component separation is, obviously if we can't approximate the closure, we might have to separate the layers within the subcutaneous and fascia layers. Hold on to the tissue, pull up on it, and typically the doctor is going to bovie in between those layers so you have more skin to give it more approximation. Otherwise, you know, the closure is not going to be really well. The point is, Kochers are a traumatic type of clamp. What you're grabbing onto, it's not going to let go. It's going to hold on to it pretty good, right? Kocher clamp. Again, you have a smaller version of that, right? You can see my common theme here, in my opinion. Again, give me your opinion about what these instruments are typically used for in your life. Obviously, we have the Kocher. There's probably numerous other examples. I'm just giving you a brief description, only because I'm trying to make this video as short as possible. I don't want it to be 3 hours long, because you guys probably will tune off. We have the right angle. Get back there, Kocher. Right angles, all right? Is that a right angle? Doesn't look like a right. It's a right angle, all right? So a right angle clamp. What are we using that for? Wow, in general tray, I can tell you in vascular, probably the most common. They'll come a little bit smaller, this in vascular. What are we doing here? We can use it as blunt dissection around tissue, right? Maybe license of adhesions. I can see him going through the adhesions, open that up and boving right in between that. And it helps with that kind of adhesions and breaking that down. I mean, I spent hours on license of adhesions on the small bowel. Obviously from previous surgeries, you got scarring in there. That's one way you can use for general. For vascular, you're going around vessels, right? Carotid comes to mind. Maybe you're using vessel loops. You're coming around. You're isolating that carotid. Umbilical tape. You're just kind of passing under that vessel. And obviously a DeBakey on the other side to grab it, right? So right angle is really, you can't get confused on that one. Now there is something called a mixer, but we won't get into that. Or Gemini. There are a lot of names for these. But right angle, typically doctor will ask for a right angle in general tray. And you can't really mistake it. It's at a right angle, hint, hint. And you can't really mistake it. It's at a right angle, hint, hint. Next up, the sponge stick, otherwise known as the Foerster sponge stick for CST purposes. Obviously the names are important. Why is that? Because if you get out there, they will have their own variety of names. But for CST certification purposes, we need to know what the correct name is. Because they're not going to ask you the sponge stick, they will say the Foerster. What goes on here? Who can tell me? Obviously, Ratex, right? GYN uses it. And obviously everyone and their mother has a variety of ways they put the Retractor on here. Who's the most important? The doctor. It's his way. So learn the doctor's way. GYNs are a little bit different than general surgery in my opinion. But don't assume that one way is always the right way. Check with the doctor, make sure they're comfortable about what sponge goes on or how they want it on. But if they ask for a sponge stick, not necessarily needs a Retractor on here. Maybe they just want the sponge stick for some reason. Have a little variety. One loaded, one not loaded, right? The Foerster sponge stick. We're going in some needle drivers, right? Not very many in here. We have the Mayo Hager type of needle driver. In my opinion, when you look at these, it really bases your opinion, obviously, by length, how deep you are in some cavity. If you're down below, if you're deep inside the peritoneum, you want something a little bit longer. But if you look at these, they're a little bit larger bites. You don't want to put small needles on larger bites, right? And obviously, you know your suture sizes. Obviously, we're looking at 1, 2, as we get up in that number, we get larger needles. You want a larger type of needle driver for that aspect. As you get into the smaller ones, type of needle drivers, as you go down in the 3.0, 4.0, and you go all the way down to maybe even a 6.0 or 7.0, which is typically used in vascular, like 6.0, 7.0 prolines, use the Castro Viejo type of needle holder, which we don't have here. But what you need to remember is needle drivers are used for obviously closure, and there's many different varieties. Size is a common theme here. As you get deeper down in certain kind of cavities, you want something longer. If you're more subcutaneous, obviously you want the needle driver for that job. Scissors. We have the Mayo scissors. Obviously we have, in my opinion, a bad example of it, but suture scissors, right? Mayo scissors, cut-in sutures. Typically 99% of the time, this is what it's going to use for. This is what it's used for. You pass the doctor a suture. What's behind that? We should know for subcutaneous, the top layer, it's an Adson with teeth, and this is going to the assist, or you're ready to cut that suture, right? Straight Mayo, suture scissor, right? Cut-in sutures. Next up the bat is the Metzenbaum scissors, typically designed for delicate types of tissue. So the Metzenbaum, probably the #1 type of scissors a general surgeon will use, as it's a very blunt tip on the very end of that. It's going to blunt dissect down. Again, when you're licensed adhesion, you might be sitting there cutting. What's licensed of adhesions? Those are scarring within the abdomen, and you want to break down tissue, right? You cut through some small omentum. It's for delicate types of dissecting, right? All these scissors dissect. You just have a common theme here. Straight Mayo, typically for sutures. Metzenbaum for typically delicate type of tissue. Next up, the Bandage scissors, otherwise known as the Lister Bandage scissors. Now, what are they used for? Bandages. Now, in GYN, they can use that for episiotomies. Just joking. Bandage scissors obviously are a multi-use tool, right? You're not typically using this for dissecting tissue unless it's really, really tough. I use this in orthopedics a lot of time to cut the drapes off after the procedure. Listers or the bandage scissors, right? Next up the bat here is the curved Mayo scissors, right? What do we use this for? Curved Mayo, right? Always a common mistake for students to give me if I ask for scissors for sutures. Boom, they give me the curved Mayo. You think of curved Mayo scissors for something that it's very tough tissue, right? Right? What's some tough tissue, right? Fascia, right? Muscle. Orthopedics will use that, but if they're having trouble, they want something very tough, or have the ability to cut through something that's very tough, the curved Mayo scissor is the tool of choice. Metzenbaum scissors, this is probably a better example of the size, a little small version of it. That Metzenbaum, you can see how delicate that kind of scissor is. The Metzenbaum is typically, like I said, for blunt dissection, cutting very delicate types of tissues. All right, moving right along to forceps. I don't have very many forceps, but How you set your tray up is obviously a fine art from everyone. Everyone has their opinion on how they do it, but in the beginning, keep it simple and stupid, as I always say. Adson-Brown forceps, it has these teeth on it that typically plastic surgeons use it, and they have a better grasp onto it. So Adson-Brown is typically a top layer subcutaneous type of closure forceps or pickups. Going down the list here of forceps, we have an Adson with teeth, right? Most typical type of forceps used. Again, you can see a small one as you're moving up or you're on the top layer. This is the forceps that you're going to use for that top layer closure. Let's just say hypothetically we move down to, there's another Adson with teeth. Let's say we're down in the deeper layers. We get the Bonney. Let's say deeper layers. We want something a little bit more bite, right? Has a little bit more bigger teeth to hold on to these. Again, you have long forceps, you have short forceps. As we're deep in that cavity, we want something a little bit longer, right? And it's just the variety of forceps. We have a very small example of them, but just remember that concept as your top layer. As you move lower in that, deeper in that cavity, you want something a little bit tougher or maybe a little bit longer. As you progressively move up, we change over to these smaller Adson with teeth, right? Now, doctors have preference on what they want. But typically, most common forceps for subcutaneous type of closure is that Adson with teeth, right? Now, an example of a non-traumatic type of forceps, there it is, right? The DeBakey. You can see those line or that serration moving down the middle. You can't really mistake the DeBakey. General tray uses it. Vascular uses it. There's probably some thin versions of these in vascular. I know I do carotids all the time, and doctors want a fatter version or a lighter or a smaller version of it or a thinner version. But it's still a vascular type of DeBakey forceps. I use it as a non-traumatic. Now, when you set your tray up, maybe you guys were showing, and obviously if you're experienced, you're probably laughing at this video. But I usually separate it from non-traumatic to a traumatic type of forceps. Why is that? I just know all my traumatic are on one side and non-traumatic forceps are on one. Just what I've been trained to do, and that's what I do obviously now. Just finishing up in the back here with some type of handheld type of retraction. Obviously we're going down the list here on the retraction. Handheld, Richardson-Eastman. Again, you have a variety of sizes. Larger, smaller. Maybe you start off small with some small incisions. As the incision gets a little bit bigger, maybe they need to go to the bigger Richardson-Eastman, right? So you can't really mistake these. Kind of the most common thing you're going to find in major trays as a handheld retraction device. Probably just behind that are what they call the Army-Navy. These are obviously for a little bit smaller incisions. As you can see, you can use your common sense. As the incisions get a little bit bigger or a little bit smaller, you need the type of retraction device most commonly used for that size of the incision, right? And it is up to surgeon's preference. Jumping over here is the Volkmann type of retraction. You have a dull, or what they call two-prong, at the Volkmann. They have a dull version here. I think you can have sharp too. Correct me if I'm wrong on that. Very similar to the Senns in the aspect of sharp and dull. Tell me in the comments, why wouldn't you want to use a sharp handheld retraction on any kind of vascular case? Now, obviously you should know that, right? Yeah, you do. Volkmann retractors, Richardson-Eastman, larger, smaller version of that. Moving on to the Senn, a little smaller handheld retraction. I would say you have a Ragel version on the back of that. But these Senns are dull. Let's see if we have a sharp here. And I don't know, these are both dull, but they come in sharp or dull. And if you haven't found the answer by now, the reason is you don't have sharp. Obviously, we don't want to damage any vessels or any delicate tissue. So you want to have a dull version of these retractors if you're around vessels, right? Doing a carotid, we don't want to pull out the old sharp. All right, some self-retaining type of retractions devices. The Weitlaner, right? What's self-retaining? It has a lock-in mechanism where it's going to open the actual incision and it's going to stay there, right? We don't have to constantly retract manually. This does it on its own. Again, this also comes sharp and dull. You need to be aware of what vessels, what anatomy you're around to make sure you have the proper one. You don't want to have sharp anywhere around objects that are going to be problematic. Now, if you saw the Weitlaner, what's the major difference here? Right, a little small version of the Cerebellar retraction device. Right, just kind of example. This kind of, I would say, probably falls more in neuro. You have a larger version of this, maybe the Meyerlin, the Cerebella. As typically has more of an arch to it. As you get deeper down into that incision or opening, it's going to provide better exposure by pushing the fascia out of the way, while the Weitlaner is more subcutaneous on the top layer. Next up, just to go, some clip appliers. These are some repurposed type of clip appliers. They come medium or small. Obviously, these are saying that we have to load up on what they call blocks or boats. They come blue and they have the old clips in here. We keep these preloaded. I would have blue and a white version of these, which is indicating the size, ready to go at all times. What do these do? These are clamping off vessels or any kind of, they provide hemostasis if there's bleeding on small vessel bleeds. They also come disposable. I think a lot of doctors go to disposables because if they need it in a hurry, not to say that we can't load them up, but sometimes there could be some failure of loading that or the clip falls out. And if you're trying to clip vessels and they're bleeding, you can see how that can be problematic. Not to say that you're going to be the one not loading it right. Last but not least, the old ribbon or the Malleable. What do we use this for? It's a flexible retraction device. Let me know what you use this for if you're out there in the field. What I typically see this used for, and a lot of the times, are closures. They come in many different sizes. Midline incisions. This is a general tray, so let's talk about that. A midline incision. Why would we need to put that? You know, we're using a PDS, some kind of Maxon for that closure. We're closing that layer, peritoneum, we're moving right up. Those are large needles. We need something underneath in that wound as they're closing. This provides a little protection so you don't perforate the bowel. You can start off really big on these and then start off really small. Believe it or not, this is probably, if I read that correct, the most common thing used, or I'm sorry, most common thing lost within the belly, because somehow as you're doing that final closure, it gets sucked up in there and it's gone. How could you not miss this on account? I have no idea, but I read a little report on that. Let me know if you've seen that report. All right, the Malleable or the ribbon, right? Off to the side here are some examples of some handheld larger retraction devices, otherwise known as Deavers. These Deaver Retractors are for probably some big open belly cases. Maybe you need to hold back the ribs. Maybe you're doing gallbladders or you're doing any kind of upper epigastric region up in the upper layer there. These are larger held hand retractors. You can see how they come in variety of sizes, obviously really big. But you see how they have that arch? It comes around, if you're opening that belly, but it kind of goes in the contour of the actual ribs and you retract back, right? Large Deaver retraction. And obviously a smaller version of that based on the anatomy. You really can't miss this one, right? It has a heart on it. Now, otherwise known as the Harrington type of retraction device, sweetheart retraction. What surgery are we going to use this for? And what does it retract back? What do you think? Well, I'm going to tell you, right? Cholecystectomy, the gallbladder, right? Typically retracting that liver bed back. Again, it has that arch and a good contour around the ribs. If you just picture that kind of liver, you push it back because you know, if you don't know by now, the gallbladder lives on the bottom of the bed of the liver, right? We have to isolate that. Sweetheart, obviously, it probably can get used for multiple things, but in my opinion, that's a really skinny version of it. But in my opinion, that's what the Sweetheart or Harrington retraction device is used for. Well, that was just my example of the major tray. Right, this is my first type of video doing this, and I probably made some mistakes, but I'm just gonna let it ride. Hey, let me know if you see any mistakes. And please comment on this, because the more likes you put on this video, obviously the algorithm is gonna make that a little bit more accessible to everyone. And it's fun to do. But as students, I would like you to look at it, see if I'm wrong on anything. What is your input on these? What kind of research did you put into it? What do you think? That's it. The major tray. I'll see you next time, guys. All right, class dismissed.